Hello, my name is Dr. Evan Goldfischer. I'm the president of LUGPA, the Large Urology Group Practice Association, and I'm a practicing urologist in upstate New York with Premier Medical Group of the Hudson Valley. I also direct the research program there. I'm the co-founding CEO of the practice, and I'm the founding CEO of the research program. And it's my pleasure to talk to you today about prostate cancer and treatment options. This talk is sponsored by Boston Scientific Corporation. Here's the agenda for the lecture today. We're going to give a brief prostate cancer overview, talking about the anatomy, some of the statistics, the diagnosis and treatment options, and then we're going to focus substantially on the radiation treatment overview and a product made by Boston Scientific called SpaceOAR Hydrogel. So when you look at the anatomy, you can see the prostate sits directly on top of the rectum. This is kind of a sagittal or side view. And it sits right at the exit to the bladder. So the urine actually traverses the prostate through the urethra as it exits the body from being stored in the bladder. And it's, again, the prostate sits right on top of the rectum, and this is important to note for later in our discussion. About 1 man in 8 will be diagnosed with prostate cancer during his lifetime. And prostate cancer is the second leading cause of cancer death in American men, just behind lung cancer. In 2022, we estimated there are about 268,000 new cases of prostate cancer. There are about 34,500 deaths from prostate cancer, which is dramatically down from the 45,000 deaths that I saw when I started my training almost 30 years ago. The 5-year relative survival rate for localized prostate cancer stage is greater than 99%, and the relative survival rate for all stages combined is 98%. The 10-year relative survival rate for all stages combined is about 98%. So this shows you that despite being a very common cancer and the second most common cause of cancer death in men, over the last 20 years, we've made a lot of progress in treating advanced prostate cancer, and we have a lot of new agents that are out there to help extend a man's life. Screening, that is detection in a patient without symptoms, is done by principally 2 ways. The first is a blood test, which is called prostate-specific antigen. PSA, or prostate-specific antigen, is a protein that's made by the prostate. Normal prostate makes PSA, and cancerous prostate makes PSA. In general, cancerous prostate makes more PSA than normal prostate cancer. And while there are a lot of different algorithms in what is an abnormal PSA, depending on your age, ethnic makeup, race, etc., in general, a PSA greater than 4 does raise a red flag and signals that further evaluation is required. The second thing that goes into screening is a digital rectal exam known as a DRE. And in this examination, a finger is placed through the rectum to feel the back of the prostate, which is the most common place to get prostate cancer, and see if you feel any lumps or bumps or abnormalities. When we screen for patients, not based on asymptomatic detection, but rather when you actually have symptoms, this may include pain and urination, hesitancy, dribbling, blood in the urine, having to strain to push urine out. So these are patients that are clearly developing a large prostate, are developing urinary symptoms. And the question is, are they developing symptoms because of benign disease, which is more common, or malignant disease? Again, 1 in 8 will develop prostate cancer and need to be evaluated. The only way to diagnose prostate cancer is to actually do a biopsy. CAT scans, MRIs, PET scans can be suggestive of cancer, but you actually have to get tissue and look at it under a microscope to make sure that you do in fact have prostate cancer. There are generally 2 ways to do a biopsy. The more common way is to place an ultrasound probe in the rectum, and then through the rectal wall, again, the prostate we talked about sits on top of the rectum, place a needle and biopsy the prostate. Typically 12 biopsies are taken to sample the entire prostate. A method that's gaining more in popularity now is the transperineal method. In this case, the ultrasound probe is once again placed in the rectum, but then a needle is placed through the perineum, that's the skin area between the scrotum and the rectum, and guided into the prostate. This avoids piercing the rectal wall, but sometimes can be a bit more uncomfortable. Once we have the biopsy and we look at it under the microscope and we determine that cancer is present, the first thing we're going to do is give it a Gleason score. 2 is the best score you can get, and 10 is the worst score you can get. Patients on the lower end of the scale have a better chance of not requiring treatment, and patients on the higher end of the scale more commonly require treatment. For those patients who are diagnosed with cancer, we're then going to do what's called a staging or a T stage, in which we'll look at your PSA, your Gleason score, and any imaging such as a CAT scan MRI, and then decide with the PSA how advanced your disease is and what might be the best options for treatment. Other factors that are going to influence our choice of treatment will include PSA velocity, that is how fast the PSA has been rising. The volume of the tumor. Do you have a small tumor in a large prostate? Do you have a large tumor in a small prostate? Obviously, the latter is worse. Genomic testing will give us an idea of the aggressiveness of the cancer, and there may be some other risk assessment models and laboratory tests that may need to be performed in order to get an accurate grade and stage and determine what are the best options for treatment. In general, there are many treatment options, but the big 3 are radical surgery, that is the removal of the prostate, radiation therapy, which can be done with either external beam therapy, where you lie on a table and radiation is delivered to your prostate while you're awake. This usually takes 5 to 10 minutes a day from anywhere from 28 to 45 days. Or if the cancer is low grade and at an early stage, some men are a candidate for active surveillance, meaning their PSAs and digital rectal exams are followed on a regular basis, and then they can avoid treatment until it's absolutely necessary. So why don't we do surgery, radiation on everybody? Well, there are obviously risks of surgery, such as anesthesia and blood loss and harm to other organs, such as bowel. But there's also erectile dysfunction and incontinence, which are 2 common side effects of both surgery and radiation, and most patients want to avoid them. When we look at surgery, there are a lot of ways to do it. The traditional way, a radical prostatectomy, is performed by making an incision in the abdomen from the belly button down to the pubic bone. The muscles are then divided and the prostate is severed from the body, and then the bladder is resewn to the urethra. In order to minimize the incision and the discomfort and assist in a more rapid recovery, laparoscopic prostatectomies and robotic laparoscopic prostatectomies have become very popular. In terms of radiation therapy, there are a lot of different types of radiation therapy, from 3D conformal radiation, IMRT or intensity modulated radiation therapy, SBRT, stereotactic body radiation therapy. And the differences between these therapies are beyond the scope of this discussion, but there are various subtle differences between them. There's also brachytherapy, which can involve the implantation of radioactive seeds, either low dose or high dose, into the prostate to try and kill the cancer. Sometimes that's supplemented with external beam therapy as well. And then there's proton therapy, similar to external beam therapy, but the way the energy is created is a little bit different. And then, of course, there's active surveillance. Again, men who are older, who may have substantial comorbidities such as diabetes, hypertension, history of stroke, on anticoagulation, they may be more likely to die of the disease, with the disease than of the disease. So a lot of these patients, it's safe to watch, checking a PSA and digital rectal exam, and only treating when absolutely necessary. And again, we're trying to maximize the cure rate, but we're trying to minimize the risks and side effects. So minimize diarrhea, minimize urinary urgency, minimize blood in the urine, minimize incontinence, and minimize erectile dysfunction. Now we're going to focus on radiation treatment, and I'll give you a brief overview specifically on it, and then we'll talk about the SpaceOAR Hydrogel. Prostate radiation therapy uses directed radioactive exposure, such as high-energy X-rays, to kill cancer cells in the surrounding tissues. Separated only by a very small space, radiation often unintentionally causes damage to the bladder or to the rectum. That's why possible side effects of radiation therapy include bowel dysfunction with associated diarrhea, blood in stool and rectal leakage, and urinary dysfunction, the need to urinate more often, dysuria or burning sensation when you urinate, blood in your urine, or in fact, incontinence. External beam radiation therapy, again, consists of various types of energy that is generated, but the principle is the same. You lie on a table and radiation is delivered externally to your body. It's a painless procedure and you are awake and you're eligible to go right back to work the same day. Internal beam radiation therapy uses radioactive seeds that are implanted into the prostate under an anesthetic procedure that then deliver energy to the prostate that's radioactive to try and kill the cancer. These implants are permanent, and the patient does remain radioactive for a period of time after the implant, requiring him to not be around children, not have children sit on his lap, and to avoid direct contact with spouse, friends, family members, etc. Here you can see a nice CAT scan image. And what you'll see here noted in the orange in a circular fashion is the rectum. And you can see on the left side is the horizontal view, and on the right side is the sagittal or side view. And then you'll see the anal sphincter, which is right there at the bottom, followed by the penis and penile bulb, the urethra that traverses the penis, and of course the bladder where the urine is stored. And I think the takeaway message of this slide is to show you how all of these structures are very, very, very close together, and how it's easy to damage the adjacent structures when you're trying to treat just the prostate. When we look at rectal toxicity in the real world, there is a retrospective analysis. So this was done looking back in time, entitled Early Tolerance and Tumor Control Outcomes with High-Dose Ultra-Hypofractionated Radiation Therapy for Prostate Cancer. In this study, a total of 551 prostate cancer patients received dose-escalated SBRT, and 269 of the 551 patients received a hydrogel spacer, while the rest did not. And what you can see here is the percentage of late toxicities with and without SpaceOAR. In the blue, you can see gastrointestinal side effects were about 1% with SpaceOAR, where the patients who didn't get this SpaceOAR had about 6% gastrointestinal side effects. We talked about those before. And then you see the genital urinary complications, about 15% with patients who received the SpaceOAR Hydrogel, but almost a third of patients, 32% of patients had significant urinary side effects if they did not get a SpaceOAR Hydrogel. So the use of a hydrogel rectal spacer was significantly associated with reduced late GI toxicity and lower odds of developing urinary toxicity later on. Rectal radiation is often unavoidable. And again, the close proximity of the rectum to the prostate is what leads to rectal toxicity, because the radiation can affect the rectum as well. There's also prostate movement in between the radiation treatments that can affect how the radiation is delivered. And there can even be prostate movements during the treatment, which can affect how the radiation affects the rectum. So what you'll see here on this slide on the right side is how the SpaceOAR is interspersed between the prostate and the rectum, acting as a protective barrier to the rectum. The rectum is the organ at risk, or what we call the OR, of receiving unintended radiation. We talked about the rectal toxicity and complications being bleeding, frequency, urgency, pain, and occasionally you can get a fistula, that is a connection between the rectum and the prostate, or the rectum and the bladder, so that urine leaks directly into the rectum. And this can significantly impact the quality of your life for years to come. And therefore, a lot of patients who don't get the hydrogel spacer and have these side effects often say that the treatment was worse than the disease itself, because it really affects their quality of life. So the benefits of the SpaceOAR Hydrogel is that it's placed between the prostate and the rectum, and it's designed to reduce rectal wall radiation exposure. The SpaceOAR is naturally absorbed by the body after about 6 months and removed through the urine. So 6 months after you've had it placed and you've completed your radiation therapy, the SpaceOAR will no longer be present. The material is a synthetic, biocompatible, non-toxic, and it's absorbed in about 6 months. Made mostly of water and polyethylene glycol, which is used in many medical products, including artificial tears, prescription drugs, and medical implants. It's a brief outpatient procedure that can be done under local, regional, or general anesthesia, often in a doctor's office or an ambulatory surgery center, not requiring a hospitalization. Again, the SpaceOAR Hydrogel is designed to provide space between the rectum and the prostate, reducing high-dose radiation to the rectum. Control patients were 8 times more likely to have a decline in bowel, urinary, and sexual quality of life compared to the SpaceOAR Hydrogel patients at the mean follow-up of 3 years. And this is piggybacks on some of that data I showed you earlier on the slide comparing hydrogel spacer versus placebo. Hydrogel spacer versus observational therapy in the treatment of prostate cancer. So the clinical results basically says that more space, that is elevating the prostate off the rectum, results in fewer rectal complications, fewer urinary complications, fewer sexual complications, and a better quality of life. There have been over 75 peer-reviewed publications documenting the success of SpaceOAR Hydrogel. It's used in many of the leading cancer centers in the United States. It is reimbursed by Medicare and many private insurance companies, and over 50,000 patients have been treated worldwide. Thus, one could almost say it's becoming the standard of care now for patients to receive a hydrogel spacer prior to undergoing radiation therapy. In this slide, you'll see a patient testimonial talking about the success of the hydrogel spacer, how easy it was to have it implanted, and the protection that it afforded.
I was diagnosed with prostate cancer. The level of cancer required medical intervention and was not a matter of wait and see. The 2 doctors I saw were Dr. Preston Sprenkle and Dr. James Yu, and both gave me a great deal of confidence that my problem was manageable.
When you're trying to radiate the prostate with radiotherapy, you always have to add in a margin. You have to expand your volume to allow for movement and error. Prior to SpaceOAR, that margin went into the rectum. With SpaceOAR, it allows us to treat the prostate without compromising at that border between the prostate and the rectum, because that border isn't there anymore. There's a big space.
Dr. Yu, our radiation oncologist, brought it up to me one day as this interesting new technology that allowed them to deliver the same radiation treatment with the same curative doses with less toxicity. By increasing that physical space and decreasing that radiation dose, it really preserves a man's quality of life.
The SpaceOAR treatment is not a medical process or procedure that needs to be feared in any way. There's no pain involved. There's very little impact on a person's lifestyle or even on the day that they have the treatment.
For the patient, I would say the SpaceOAR is a great option because it has minimal side effects, the procedure is easily tolerated, and it really has a tremendous benefit. I would encourage any of my patients who are going to have radiation that they ask about SpaceOAR, and they ask if that is something that the radiation oncologist is comfortable using. I strongly encourage all of my patients who are having radiation to have a SpaceOAR placed before treatment.
Especially if you have a very curable cancer, right? And you're deciding between different treatment options. Quality of life is just as important as beating the cancer. Most physicians are probably like me. You know, sometimes you wake up in the middle of the night and you wonder about your patients and you worry about them. Especially as you're planning their radiation treatment, having a space there between the prostate and the rectum reduces a lot of that worry.
I've always been a very active person. It has not diminished my abilities to do the things I love and to do more of them. And if a friend or a family member came to me and asked me what would be the best way to handle prostate cancer, I would definitely recommend the SpaceOAR. For me, it has had very little consequences, either the day of the treatments, the weeks and months afterward, several years afterward. My greatest hope that it would be available to all persons everywhere.
And if you have any further questions about the hydrogel SpaceOAR, want more information, you can visit SpaceOAR.com for more resources, including SpaceOAR Hydrogel Physician Locator, to find physicians who have experience in implanting this, a patient helpline, and some educational materials. And that concludes the fine print and the talk. Thank you very much for your time today. I hope you've enjoyed the presentation and found it educational.